Thank you. I know there are a few people standing in the back. Some of you are doing so because you're off in a bit to other areas. I am blinded by the lights, but I can see there are seats up here, so please come forward if you would. And also, because the speakers can't see the audience as well, we won't know if you're walking in or walking out, so no worries. So it was a pleasure to come to the American Medical Association 2 years ago, and I really didn't know the opportunities that I personally would have to continue my passion on working to improve medical education. We have some of our publications in the back of the room. We've been working very actively on making recommendations on admissions done hand in hand with the AAMC recommendations on physician reentry and on workforce. We also put out a monthly newsletter. It's on the bottom there, AMA MedEd Update, a lot of interesting topical things. And in that newsletter this week is a place that people can go to one click away to look for leadership opportunities at the AMA. And again, with the section on medical schools and our councils, et cetera, I hope you think about it because it's a great place to have a big impact. The dream for me now has come to fruition, and that is to be working on a level that may make a very important contribution to what we understand about medical education. It's through a wonderful group of schools that preceded me at the AMA, and they have graciously let me lead them over the last 2 years in designing and implementing a large study on the medical education learning environment. I'd like one of the leaders of the schools to tell that story. Charlie Christensen at the University of North Dakota actually preceded this study by having done a fair amount of work that we've based our protocol on. So he's the perfect person to speak with us. Charlie, please.
Thank you, Susan. It's a pleasure to be here, and I'm really happy to have the opportunity to share this activity with you. Perhaps some of you have heard about it last year, or will be hearing for the first time. I'll be telling you about the overall organization, ISTEP, and then we'll be focusing more specifically on the learning environment study that we're doing. ISTEP, Innovative Strategies to Transform the Education of Physicians, is a consortium of medical schools convened by the AMA around research in medical education, really with an interest in professionalism activities, although not exclusively focusing on that. The ISTEP consortium now numbers about 40 U.S. and Canadian medical schools who have participated in some form. Its mission is to improve the care of patients through advances in medical education research. The initial group was composed of 16 schools or consortia, so there were a total of 27 schools involved. And while we're going to focus on the Learning Environment Project, there are a number of other activities that the ISTEP consortium has been involved in. For example, you see there a sound prescribing education project. A group of schools in the consortium took part in a program. You may remember there was one of these settlements with pharmaceutical companies that led to some funding for training physicians, medical students, and residents around sound prescribing practices, and some of our schools were involved in that program. Another ISTEP activity that we didn't put on the slide, but some of you may be aware of, is an activity funded by NIDA to develop education for residents and medical students around substance abuse. So the title of that is Centers of Excellence in Physician Education. So again, 8 medical schools, 4 of the individuals or consortia of the ISTEP group have taken part in that. And actually, if you go down to the NIDA booth, you'll see the products of that collaboration, and they're also posted on the NIDA website. But we're going to be focusing on the learning environment study. And a lot of schools, probably many people in this room, are concerned about their learning environment and wondering how they can measure it, how they compare with other medical schools. The LCME MS31A calling upon us to assess whether our learning environments support desired professional values and attitudes is a driver in that, in addition just to a general desire to know whether we're doing well by our students and producing the product that we want to. So this was a topic, the learning environment and its impact on our students was a topic of discussion among the ISTEP group. And it's hard for me to believe, Susan and I, in prepping this, I said, is that spring 2010 really right? Because we actually started in August and September of 2010 with the data collection. Yeah. So it seemed to me like it must be longer, but it really wasn't, although the group had been discussing the idea before. This wasn't totally brand new. We had been talking about what to do. But really, just in spring of 2010, the group came together and really dug into designing this study. We really wanted to look at the impact of the learning environment as perceived by students on selected outcomes. These are things like empathy and coping, professionalism, and patient orientation, patient-centeredness of our students. And to look at institutional variables that are that might be related to that. So we're also looking at public versus private schools, the size of the medical schools, some factors of the curricular model. And some people have pointed out, Pat Carney and others in the last decade, that one of the problems with medical education research has been that it tends to be at a single institution. So we look at what we're doing in our own institution and maybe have an intervention. But to really get an idea of the impact of different forms of education, it would be very helpful to have a number of different medical schools with different characteristics, which this consortium allowed. I will also, for you social scientists in the room, tell you that we did have a conceptual framework. I'm a clinician myself, but the social scientists in the group believed in having a conceptual framework, and it's Bandura's social learning theory, which says that learning is a product of reciprocal interaction between cognitive, behavioral, and environmental influences. People learn from one another via observations, imitation, and modeling. And this leads, I guess from my perspective, we wanted to look not just at individual students, but at the environment and their interaction. Although if you want to go into that in more detail, I am not your person to do that. You will need to talk to one of our social scientists. In terms of the study design, we were helped by the fact, I am going to take a personal moment here to give credit to my colleagues at the University of North Dakota, because as Susan pointed out, we had done kind of the prototype, the pilot study for this for several years. There was actually, I should have mentioned earlier, part of the reason the ISTEP project was able to, I think, get off the ground so quickly and people were able to work together was that it built on a previous successful AMA collaboration in medical education called the STEP program, Strategies for Teaching and Evaluating Professionalism. About 10 medical schools received some funding to develop teaching and evaluation around professionalism and to meet together and share their results. And that worked so successfully that there was a desire to continue it that led to the ISTEP project, and part of the selection of that name was to kind of echo the STEP project. What we did at North Dakota, one of the activities we did under that original STEP project, one of my colleagues, James Hazelton, who is a physiologist but had an undergraduate major in psychology, was very interested in the development of moral thinking. And some of you may know there is a defining issues test that has been developed according to the Kohlberg's theories of development of moral thinking, but this instrument is specifically directed towards health profession students. And under his leadership, we started administering that test to our medical students on admission at the end of the second year and at graduation. Had been doing that for, I think we've been doing that for about 8 years now, 8 or 9 years. And that project about 5 years ago was taken over by my psychologist colleague, Roseanne McBride, who added a number of other instruments looking at patient-centeredness, empathy, tolerance for ambiguity, etc. So we had been doing, when the group was interested in this, we kind of proposed to them this as a framework, and number one, it provided an outline of how to do it, and some assurance that we had been doing it for a number of years, and it was actually a doable project. Could be done without a lot of resources. So the group coalesced around that and decided to follow that same general model. We take students at their enrollment in medical school, and at periodic intervals thereafter there's a little flexibility, because I say at the end of 2 years, not every medical school has 2 years of basic sciences now, some have only a year and a half. So generally the second measuring point is at the end of the preclinical experience, and then at graduation. We did, at that 2010 meeting, spend a lot of time actually going over. The major activity was selecting the instruments, and Susan's going to talk about those instruments in just a few minutes. And we actually did a very interesting thing that Susan introduced, an activity that she introduced that I have subsequently done, which is we all took all of those things ourselves, and it really was a great learning experience. It's one thing to read the article about the validation, but to actually take it, you learn a lot. So the group studied many instruments. We were not here to develop any new psychometric instruments. We wanted to use existing validated ones that were widely used. We took them ourselves, and you'll be hearing in a few minutes which ones we're doing. Developed a format for administering them using either paper or web-based data. The University of Michigan serves as the data coordinating center and has been wonderful in that job. The first cohort in 2010, 12 of schools participated, and people heard about it, wanted to join in, and 29 schools are in the 2011 cohort that just started. In terms of numbers, 1,850 students in the 2010 cohort, about 6,000 in the 2011 cohort. Since there is a research element to this, there are IRB protocols. University of Michigan submitted the protocol to their IRB and had an overall approval. Then each school did that, submitted individually to their own IRB. I will make a point here. The opt-out rate refers to the following. Many medical schools, of this group that are taking part, most, I would say, of the medical schools say that this is not, for the medical school, not a research project. This is a way of evaluating the impact of curriculum and learning environment on students, so as a part of our overall assessment, and thus is mandatory for the students. However, the research element involves sharing that data with the national collaborative. So on that, students have informed consent and a right to opt out. So in most medical schools, students are required to take the instruments, and the medical school gets that data, but they may opt out of having their data shared. A few medical schools actually do not require it of their students, and the students can opt out of the whole thing. But there was an overall opt-out rate in the first cohort of 13%, with some variation between schools, which is quite interesting in itself. If you can see that, yes, you can see it. It shows up better on the screen. The squares are the original schools, and, I guess there were 12 that took part of the original ISTEP schools that took part in 2010, and 3 more who hadn't joined in 2011, and then 14 new schools joined in 2011 as well, bringing the number up to 29, right? And these are the schools by name. And I think this is the point. Susan is going to now take over and give you more detail.
Thank you, John. I was just going to put that last slide up there. You know, I was at a meeting yesterday, and we happened to be talking to a few of the deans, and you know how it is in these schools. These things happen at lots of different levels, and if you're not participating in this, you may see your school's name on here and may not have been aware of it. We are really making an effort on that this year to get the word out at the local level, and also to return information as best as we can through the school leadership to the students who are so graciously participating in this study. The other part that I wanted to emphasize, because it does allow this study to do things that perhaps cross-sectional studies cannot, By longitudinal, we mean we follow each student individually across their 4 years. So they have been de-identified to the Research Coordinating Center, but they have identifiers so that we are following each of them as individuals. You know, it's interesting to think about how do you measure the learning environment. There are so many ways to go about it, and there are so many ways that we aren't anywhere adequate for what we really want to know about the learning environment. In this case, we had no major grant. We had very enthusiastic people. We wanted also to be respectful for students, since most of us come from either dean's offices or other places where we know how much burden the students already have in filling out forms. So as Charlie said earlier, we picked measures that had already been published in the literature. We know what their parameters are, and we also picked them by convenience based on how quickly you could take them in an amount of time that would work for a student. And so this is our battery of measures. The first one, the medical student perceptions of the learning environment, has been out in the literature for about 20 years. We're using a shortened version, and I'll say a little bit more about that. But 17 items. Patient practitioner orientation scale, which is thought to be a measure of patient-centeredness, willing to work collaboratively with patients. The Jefferson Scale for Empathy, this has really become a bit renowned, and we're very grateful to Dr. Hojat for allowing us to use the scale as part of this, but this is the empathy scale that people like to quote, that between first year and fourth year, students seem to be losing empathy. This is the measure that has been used for that. Ways of coping in terms of, again, traits that the students themselves bring and carry through medical school, tolerance of ambiguity. At the same time, we've collected some demographic information on the students, and of course we have all of the local data at the school level, including the curriculum, size of class, and other things. The students, when they take this battery of 5 scales, it takes about 20 minutes. They're allowed probably an hour at every school, and most have reported that it's not any longer than 30 minutes. Also, we allowed the schools either to give the measures in a web-based form or a paper form, depending on how the school uses the time that they're with students. So some of them are with students in orientation, and they have them in front of them and wanted to pass it out. Others allowed them to take it over a little bit different period of time. Of course, that introduces, every one of these things introduces another variable, and we're tracking all of those. One very fascinating thing that came out to us quite early is that there was a difference in the opt-out rate between those that took paper and pencil and those that took the web-based survey. And we have lots of theories about why that is, and maybe at the end, if you want to talk with us about that, we can share that as well. But the folks that did it on web opted out, I would guess, at about twice the rate of those that took it paper pencil. Just a little bit about the 2010 cohort. The actual number of students, 1,878. Of course, the data's been cleaned and double-checked, and I'm very grateful to Larry Gruppen and the team at University of Michigan for all their help in the data analysis. The demographics are here. You won't be surprised by most of what you see. We've got enough students in here that it's fairly reflective of the national averages for medical schools. One of the things that was fascinating, we asked them had they ever worked in health-related areas, and more than half had. When we asked what that work was, of those that worked in health-related areas, 25% of those had been EMTs, 12% had been psychologists or other counselors. So very interesting and rich information to just think about as we start to look at our cohorts. Now, the outcome of interest, and that won't be our only outcome, but I guess you might call this our independent variable, the medical student's perception of the learning environment. As I said, this is an abbreviated scale, 17 items. The literature comes from Rosenbaum, Academic Medicine, 2007, and those of you that are interested in the other instruments, we can share some of that with you after the session. There are 7 subscales, and the subscales are ones, as you think about the learning environment, I hope make intrinsic sense to you. Breadth of interest means the student reports that they're encouraged to keep a balance in their life outside of medical school, to keep that breadth of interest. Supportiveness in these questions means the student says the faculty and staff are supportive, want me to learn, encourage me. The organization is about the curriculum, and again, the questions are such that they have to do with the curriculum is integrated in a way that makes sense and allows me to build on learning that I've had. So just to give you a better picture of some of the measures that we can look at for our outcomes. Now, specifically, in terms of the subscales, I just wanted to give you a flavor of the way the data is starting to look in a very preliminary way. This is not for you to read, but just to look at the pink bars. The breadth of interest, as I said, is the subscale that says the extent to which students are encouraged to develop and sustain their activities outside of coursework. And along the bottom are the actually 16 sites. We have 12 schools, but we're breaking out the sites. Some have sites differently across the state, or even one has a site in 2 states. So these are the schools individual, by school now, not by students, and then this is the scale, subscale for breadth of interest. The higher is the more positive. But I show this because this is the mean of all the students in terms of what their answers were. And when you look at the box plots of their answers on the subscale, you see there's a lot of variability between the schools, which is rich for us in a study like this, because we can start to try and understand why is that and what does that mean. And then within any school, there's quite a variability in terms of the students within the school. So they're not all just checking off 5, 5, 5, at least we hope they aren't. You all have done evaluations, seen that before. Now, the other interesting thing that comes to us then is to look at what are the associations between the measures that we have and other things of interest. So, for example, one might hypothesize now that, if you had a large class size, that the subscale measure on the student interaction would be low because they don't have as much chance to get to know each other. So if you take and plot class size, the schools going from less than 50 up to 200, again against the subscale here from their perception of the learning environment, with 5 being the highest. The questions here are students in school get to know each other well. That's the exact question that's part of that subscale. And what you see is, there's a trend, but it's not significant. And so right now, at least with a large N in terms of students, smaller N in terms of medical schools, and this of course is by medical school, but some of them rate very high with large class sizes, some of them much lower. So this hypothesis, certainly is not refuted or confirmed by just an association like this, but these are the kinds of questions that we can start to evaluate. I also want to thank Michigan very much and all of our team on ISTEP. We have some fabulous methodologists that are working with us, and while we put this study together to be hypothesis generating, knowing that we wouldn't know at the onset what we will find out, at the time now that we're looking at the data, we are wanting to hypothesis test our questions. And so we're not doing the very tempting thing like going in there and dragging through this data and trying to find out what will we find out. And we're trying to be very thoughtful in the way we ask the questions of the data so that we can put the hypothesis forward and see what the data shows to us. The last meeting that we just had last month with all of the researchers and clinicians from ISTEP really talked about how dissatisfied we are right now with what we're able to capture. You know, scales like this are interesting, but if you do take those scales yourself, you'll see the limitations if you don't already understand that. And we wanted to be sure and say, we aren't only interested in the learning environment, we really would like to understand the dimensions of professionalism and what is promoting professional attributes and what might be detrimental. And so we had a rich discussion with a couple of colleagues that were invited to talk to us about how do you measure, how do you think about professionalism. And as those of you in all your school settings have tried to talk about this among faculty, staff, and students, it's a bit difficult to pin down. I really appreciated Louise Arnold and her colleague Stern at the University of Missouri, Kansas City, wrote an article that says professionalism has to be based on core things like clinical competence and knowledge, communication skills, and ethics and legal understanding. But that's the base, that's not enough. And they describe other elements that need to be present: excellence, humanism, accountability, altruism, and these are the pillars above the base on which professionalism rests. So it's a lovely, rich way to think about it, because when we talked about how would we measure professionalism, we had to consider so many dimensions, and we don't have the answer yet, so if you all want to talk to us about it, we'll very much welcome that. For example, do we really want students to describe their self-perceived professionalism? I think most of us would prefer direct observation in some way. People can put on a great act in their OSCEs and other places when they're being observed and look like professionals at a superficial level, but then when you go behind and ask the folks on the team, as we're now doing as we do team care evaluation, obviously the dimensions of professionalism have to be deep and held intrinsically. And the other dilemmas that I have here about how much can we do now that could be qualitative to add to the quantitative. And clearly you can see that now we have an opportunity for either sub-studies or even interventional studies, which ultimately is the interest of this group. Okay, now that we know what we know, how do we improve the learning environment? And that's the most, I think, interesting part to all of us. So with that, we won't take questions until we've just finished up the last part of the panel, and then we will have about 15 minutes at the end. I would very much appreciate if Art Ross would come up and speak with us next.
Well, good evening, everyone, and thank you, Susan, and especially for remembering our time in Wisconsin. It really was special, and a privilege indeed to share a podium with Dr. Lazarus. All this talk about social scientists and hypotheses got me to thinking they'd probably have a field day with a group that has something like this when their cocktail parties to the right, to the left, and all the way up and down the hall. And this would not have been my predicted outcome. To see all of you here tonight and this room filled is, for me, and I know for the other panelists, very, very gratifying. And I want each and every one of you to know that we are very thankful that you've taken the time to be here tonight. And I'll assure you, as the last speaker, in between you and those attractive nuisances, that I won't go any longer than my promised time. But thank you so much for being here. I do get to serve this year as the chair of the section on the Governing Council, the AMA section on medical schools, which is one of several key AMA policy groups that relate to medical education. You see a listing of them here, and it's a terrific group of policy groups that do collaborate and work together. We should recognize, I think, that the current chair of the Council on Medical Education, David Swee, is here with us tonight, and it's been my pleasure this year as his counterpart chair on the section to work with him and do, I think, some very productive things together. Insofar as the section is concerned, the types of things that we do, we believe are those that will help the AMA to address some of the key medical education and practice issues that come before it. It's the section's responsibility as educational programs become necessary to provide the forum whereby they are presented to the membership and to those others who'd be interested in attending. We do have a chance to both review as well as propose AMA policy, and we are also given the responsibility as innovations in medical education, such as what you're being treated to this evening, become current in choice to inform the membership and the greater medical education community about it. Perhaps one of the greatest things that we get to do is to mentor the students and residents in the sections on students and residents, and we do get to spend a fair amount of time working with them, and it's just a joy, as all of you who are here this evening know, to have that opportunity to work with these brilliant and bright young folks. This is your current 2011-2012 SMS Governing Council. It's been my privilege to be chair. Next year's chair is Maria Mia Savoya from the University of California, San Diego. Last year's chair, Ken Simons from the Medical College of Wisconsin. We have a delegate and an alternate delegate to the AMA. This year's delegate is Don Eckhoff from the University of Colorado, and Mike Grossman is our alternate delegate from Arizona. 3 members at large, each of whom serve a year term: Jay Fogarty from Florida State University, Dan Ornt from Case Western Reserve, and Bob Sokol from Wayne State. And our current liaison to the AMA Council on Medical Education is Louis Ling, who's right here in the front row, as he always is. So I want you all to know that this is a great group to work with. It really has been an honor and privilege for me. And being an even year, every one of the positions that you see, delegate, alternate delegate, the members at large, and this year our liaison to the council, all come up for election. So we are actively seeking nominations of people who would like to move into one or more of these positions. You're welcome to self-nominate. You're welcome to nominate others. We hope that you would do so. There is a lot of information about this on the section website, and in addition, Susan and myself and any member of the Governing Council would be happy to speak with you or anyone that you think might be interested in serving in this capacity. The application deadline will be in early March. The nominating committee will make its recommendations in the spring. And again, please nominate or self-nominate if you'd be interested. Some of the things that we have been doing over the past year or two have been, we think, very important to the medical education community. You've heard a little bit yet this evening about the issue of addressing medical student mistreatment. This is something that came to both the AAMC and the AMA from the LCME as an issue for which we were seeing increasing evidence of its presence. It concerned all of the members of the LCME, as I know it concerns all of you, and I'm really very happy that the section is being in a very collaborative way, working with others within the AMA sections and councils to try and find ways to better define, identify, and address this difficult issue. The availability of clinical sites for our students has become an issue. This is multifactorial, not something to get into now, but again, we've tried to take a lead in addressing this important matter. We do feel that it's our responsibility to showcase curricular innovations that are occurring within schools, not just new schools, but existing schools, and at both our interim and annual meeting presentations, we try to take some time to have as a part of our program something that showcases this. And an example of that was something that those of you who may have attended our session here yesterday got to see as relates to graduate medical education. We're concerned about funding issues in graduate medical education, but also innovative strategies to address some of these funding enigmas, as well as ways that our graduate medical education programs can better serve state workforce needs. There are a number of AMA educational resources. I won't take the time to go through each one of these, but these are all available to you, and especially underscore the AMA MedEd update that Susan had spoken with you about. You know, I had a very interesting opportunity about a month ago with Dr. Swee to visit the AMA. The two chairs get a chance to have a very deep dive orientation visit during the fall of their chair year. And it was amazing to me, and I know to David as well, to see the really vast educational resources that exist within the AMA. And it's very deep and something that serves as a resource to all of us that have got any involvement whatsoever in education. Now, this is a very select group here. We're at the AAMC meeting, and it's almost a certainty that everyone in the room has some involvement with academic medicine. And oftentimes we are asked the question as to the relevance of the section on medical schools in the AMA to academic medicine. We in academic medicine are fond of acronyms, and on the screen now you see an alphabet soup of LCME, ACGME, ABMS, NBME. You all know what these stand for, and the AMA has the opportunity to nominate members for all of these. So in terms of if I am in academic medicine, is there any relevance of the AMA to me? If there's any acronym you see on the screen that impacts in your life, the answer is yes. I'm really delighted tonight to see that a number of the AMA appointees to the LCME are here, and want to recognize that the current co-chair from the AMA is Jeff Gold, who's taken the time to be with us tonight in spite of an incredibly busy schedule here at the AAMC meeting. So lots of opportunities, not the least of which are positions on ACGME residency committees. We have a February 1st deadline for those, and we've got 14 positions available to be filled, and hope that, again, you'll consider nominating or self-nominating. The other question that comes up oftentimes is the question of membership in AMA, especially for those of us who are within academic centers where sometimes budgets become more constrained than we'd like. And I want to recognize our wonderful past chair, Ken Simons, who, in spite of the Tyndall effect of these lights, I think is in the back row. But Ken's legacy, as he did his chair year as section chair, was to work with Jim Kirshner and others in the membership group here at the AMA to create something new in terms of a membership plan. And it goes something like this. If your dean and 5 of your key leaders are willing to sign up and become members of the AMA will provide a 20% discount for that group. And if you have that core group and then go beyond it with other faculty members, that discount will apply. I can tell you that from our vantage point at our school, it became a no-brainer. We had these people involved, and this represented an instant savings. And from the perspective of how you're allocating your resources and using these precious dollars, we now have money that we're putting into other key programs that help us meet our mission as a result of the AMA's willingness to have done this. There are a number of other schools who have done this as well, and several others that are currently considering it. And as you go back to your schools, count the number of people that you have in the dean's office that have got AMA memberships, and it may become a no-brainer to you to take advantage of this. And I'd certainly encourage you to do so. Before we get to questions, I want to mention one last thing, which is the added benefit of serving on the section on medical schools at the AMA is you get to work with the best section director in the world, Jackie Drake, and Jackie is here. And I want to say in front of this group, and I say it in front of every group that I can, that Jackie does so much for us, and Jackie, we're so grateful. Thank you for all of your hard work. Susan, I'll end with that and give you back my pointer.
I very much would like to thank the panelists today, and I'm imagining that we're just about done taping. Jim, you can help us turn off the bright lights and turn on the real lights so that we can have some time for questions and answers. Thank you. Please come forward. We've got a microphone in the center, and if you would like to say anything, I hope you will come and identify yourself while you're doing so.
Darren Larimer from